Hello, today we're going to talk about angina. Just a little refresher on angina. It's chest pain that happens in the sternum going from the shoulder down the arm. We also know that it is different from men and women, and that essentially is talking about oxygen supply getting to the heart. Two basic goals. One's to decrease the workload or decrease oxygen demand and increase the supply. So in decreasing the workload or decreasing oxygen demand, you can do it a bunch of different ways. Main way we do it is decreasing the heart rate and decreasing contractility. And we also work on the wall tension. The other thing we can do is increase oxygen supply. So besides giving the patient some oxygen, we also blow open those arterioles, get blood flow to those cardiac cells and get perfusion there, and the oxygen goes right along with it. There's three basic families in anti-anginal agents that we're going to talk about: nitroglycerin or the nitrates, beta blockers, selective agents, metoprolol. The non-selective agent is propranolol, and then calcium channel blockers, verapamil and nifedipine. Let's look at the treatment of angina, and I'm just going to do this very simply. In chronic stable angina or exertional angina is the person that's shoveling or goes up the stairs and they have chest pain with exertion. Usually we treat this PRN with nitroglycerin sublingual. Okay, they'll have maintenance therapy, perhaps beta blockers, calcium channel blockers, and as always, non-drug therapy, diet therapy. With variant angina, it occurs at rest, so you'll have chest pain that just comes along. And we also treat this PRN with nitrates to see if it goes away. These people are, let me rephrase that. Patients that are more likely to have variant angina might also have a history of migraines, Raynaud's. Things can trigger it, like smoking. Drugs of choice are like I said, we treat PRN chest pain with nitrates, nitroglycerin, and calcium channel blockers are very useful with this group. And then we have unstable angina. So you have symptoms that arise at rest and they get worse. Nitroglycerin does not work. This is a medical emergency, and they need to go to an acute care facility as soon as possible. And with this group, I need to make sure that you understand with someone who has unstable angina, we'll also treat them with some of these other drugs, but nitroglycerin will be given IV in this population for treatment. Let's look at the pharmacology. So the main drug classes we're going to talk about: the organic nitrates, calcium channel blockers, and then once again the beta blockers. So the organic nitrates, nitroglycerin is the prototype. It's a really potent vasodilator. It acts directly on the vascular smooth muscle to promote vasodilation. We use it in stable, unstable, and variant angina. It comes in lots of different forms. The IV half-life is 5 to 7 minutes, so that's pretty short. And it's highly lipid soluble. Long-term preparations happen to be the patch. For PRN nitroglycerin, it comes in a pill. And the adverse effects will make sense. Because it's such a potent vasodilator, it's blowing open the vessels everywhere. So in your head, when you vasodilate, there's no place for those for the volume to go. So it presses against your skull, causing a headache. Again, because it's a vasodilator, it can cause orthostatic hypotension. And because it causes orthostatic hypotension, our body actually compensates and causes a reflex tachycardia. It also has a unique phenomenon that happens with nitroglycerin called tolerance. Let's talk about that. So with tolerance, It can happen rapidly in high doses or with uninterrupted therapy. You can have cross tolerance to other nitrates. To minimize this effect, you start with the lowest effective dose that works. For someone who's having long-acting preparations or patches, we actually recommend sort of like a drug holiday, so drug-free hours each day. So usually what we recommend is that they'll take off their patch at night, so they should take a shower at night, take off the patch, and if they happen to have chest pain during the night, usually what will happen is they'll prescribe another drug like a beta blocker. Now, nitroglycerin will interact or compound the effects of any other drugs that cause hypotensive effects. So, yes, beta blockers do cause hypotension, as do calcium channel blockers. So you'll watch that very carefully in anyone that's also on any of these other therapies. It also can interact with some other PRN meds like Viagra. So if you have a patient that has a cardiac history and they're prescribed Viagra, nitroglycerin can be fatal for these patients, so they should not be on Viagra, definitely without evaluation by a physician, because Viagra causes very potent vasodilation as well and hypotension. So there's a lot of nursing management with nitroglycerin. With IV nitroglycerin, you require cardiac monitoring. Hopefully a central line is best with an ART line and definitely EKG monitoring. Nitroglycerin requires its own tubing. Okay. Additionally, the bottle or the vial that it comes in that you use the IV tubing should also be covered, because nitroglycerin breaks down into light. Dr. Mollenkopf says that nitroglycerin has its own tubing because it attaches to the formation of the tubing, but nitroglycerin has its own tubing, and in fact it's marked nitroglycerin tubing. Anyone on IV nitroglycerin should be on an IV pump. And you should watch very closely for any hypotensive events. Additionally, if someone's taking nitroglycerin sublingual, pills should be in their original container. No fancy pill bottles will do for this drug. It needs to be in its original container. Additionally, for anyone taking nitroglycerin sublingual PRN for an exercise-induced event, the best thing you need to do is make sure they're sitting or lying down. Remember, this is going to cause big hypotension. They're going to be dizzy, they will pass out, so they really should be lying down before they take their first dose. Give them their first dose, wait 5 minutes. If they need a second dose, wait 5 minutes. If you're about to give the third dose, be sure you call 911. For those that are receiving patches, besides having a holiday every night, taking off the patch, be sure the patch is on a hairless site. There are some indications that you can decrease a headache by placing the patch further from the head. This patch, when you do take it off, it should be thrown away and it should be rotated at other sites to promote good absorption. Another thing is the person putting on the patch should be cautious that if they touch it as well, because it can cause some, you can absorb it as the person administering the patch, so be sure to wash your hands. And the last thing that's mentioned here, if a patient's taking PRN sublingual nitroglycerin and they're taking it more often, they have to notify the provider. If it's more often, it means something's not right and they have to reevaluate. Okay, the non-dihydropyridines. This drug class blocks the calcium channels in the blood vessels and the heart, so it vasodilates in the periphery and the heart. In the heart, peripherally, it'll reduce blood pressure. It also blows open the arterioles in the heart, allowing for that oxygen to perfuse the heart. It has some electrical component in that it blocks impulses going through the SA and the AV node, and it can decrease the force of contraction. So it has lots of different uses. We're talking about an angina because it's increasing the oxygen supply to the heart. Plus, because it slows down the heart rate, it's decreasing the workload of the heart. It's also used in hypertension, dysrhythmias. It causes constipation in a terrible way. Constipation you've never even heard of before. It's like going on vacation and you can't go to the bathroom for 2 weeks. That's how bad the constipation is. All patients on verapamil should be on fiber and water therapy. Because it causes hypotension, you can have dizziness, flushing, and headache. And because it decreases the impulses through the heart, you can have partial or AV block. Anyone with any block at all should not be on this drug, and it does interact with grapefruit juice. So concurrently knowing they should avoid grapefruit juice. A safety implication with this drug is that it can be found in immediate release and sustained release. So that's something for the nurse to be aware of. The dihydropyridines, nifedipine, blocks calcium channels in the blood vessels. So you have peripheral smooth muscle and peripheral vasodilation and decreased blood pressure. But also because of this, you have a reflex tachycardia. Your body's compensating from that decreased blood pressure. Adverse effects of this happens to be the reflex tachycardia, flushing, headache, dizziness that you have with hypotension. You can have peripheral edema with this and gingival hyperplasia. Nursing implications with this is that nurses can never administer immediate release agents. It can cause such profuse hypotension it can be fatal. And because of the reflex tachycardia, sometimes it's given in conjunction with the beta blocker to prevent this. You really need to let patients know about peripheral edema, so they should be taking daily weights, and you never want to crush extended release tablets. It can be deadly. Beta blockers, as you've heard of before, are helpful in angina, and then it decreases the workload of the heart through beta-1 blockade. So beta blockers in general, and I listed both propranolol as the non-selective and the selective agents. They can cause bradycardia. They decrease conduction, so you can have decreased AV conduction, reduced contractility. Propranolol can have asthmatic effects. Metoprolol, even though it's selective, if you have high enough dose, you can have asthmatic effects. We do watch beta blockers with patients with diabetes because it can mask the effect of tachycardia. You can have some CNS effects like insomnia and depression. Patients complain of having depression. We labeled it the beta blocker blues. It's not a song, but it actually exists, so you'll be aware of that. And they also can have bizarre or strange dreams, and some patients also complain of sexual dysfunction with this drug. Now, it does have additive effects, so I did say that we might give a calcium channel blocker like nifedipine with a beta blocker. As a nurse, if they're also on a calcium channel blocker, you're going to watch not only their heart rate but their blood pressure because it can have additive issues. Beta blockers, you want to watch anyone who has heart failure and make sure that they're stable. Unstable heart rate would be indicated by someone with crackles or rales, extensive edema, and you really want to warn patients about abrupt discontinuation. So you never want to stop beta blockers abruptly because you can have a reflex tachycardia and MI has happened. So I hope this was helpful. Again, nitroglycerin was the big drug in this category. Know that nitroglycerin comes in a PRN indication, so that would be the spray or the sublingual tablet, and that's generally for exertional or PRN chest pain. Always want to let your provider know if you're having more chest pain more often. And nitroglycerin has some unique effects like tolerance that you have to pay attention to. I hope this was helpful. Again, how we treat angina is we decrease the workload of the heart or we increase the oxygen supply, and all these drugs actually contribute to it. Alrighty, that's it from me. Have a great day.